Hey, welcome everybody. Thank you so much for joining us this afternoon for the next and last in our series of Ask the Doctor webinars, where today we will have Dr. Bryan Borland joining us from Basecamp Recovery as we talk about some of the new trends and things we're seeing on the horizon in the opioid epidemic. I am Barbara Campbell. I am the Executive Director of the Dalton Foundation, and we run and support the relink.org project. And I wanted to really quick introduce our team to you. We have with us today Brittany Hall, who is our social media specialist and coordinator who helps us advertise. Thank you, Brittany, for being here. We also have Bill Pica with us, who is our data coordinator. We will be sharing some data today from relink.org, a very small sample of data, but he's the one that helps gather, aggregate, and share that. So thank you. And then lastly, but not least, we have Rachel Sobitz with us, who is our community engagement leader. And she's going to be sharing a little bit with us today as well about what she is seeing and hearing in the community meetings that she is attending along the lines of trends in the opioid epidemic. And of course, we have Dr. Bryan Borland with us, who is the medical director at Basecamp Recovery Center in Columbus. I just want to spend a brief second doing a quick overview of relink.org for those who are not familiar with it. This is our passion project for the last few years to aggregate and display resources for the state of Ohio around substance use disorder, human trafficking, behavioral health, re-entry, and most recently family resources, in addition to basic needs. So we just want everyone to know that relink.org is here and free for everybody to use as a way to help find resources for yourself or a loved one, or as a social worker or an advocate to help somebody else that is in need as well. So we'll share that real quick. This has been our focus for the past year, has been families, and we've added family services to relink.org. And we're really excited. We've been seeing an incredible amount of engagement with this part of the site. And thanks goes to Bill for getting all the data, and we're very appreciative of that. And then, as we mentioned, we've been partnering with Basecamp Recovery Center and Dr. Bryan Borland for the past, well, almost a year now on some substance use disorder education for families. And that's the Begin Your Climb. We do have information about it at the end of the webinar, but it's beginyourclimb.com. And it has a series of very short but very impactful trainings for families. It's a great way to provide education in a very small amount of time in a bite-sized way that we think it's been very impactful. So Dr. Bryan, you can share a little bit more about that at the end too, if you like, but it's been a great project, and we thank you for that partnership with that.
Absolutely. Absolutely.
All right, so without further ado, I want to just say a little bit about today. We call this series Ask the Doctor because if you have any burning questions, even if they do not relate to the direct topics we're talking about, but they are related to substance use disorder, we would love for you to have the opportunity to ask those today. So please type them in the chat as we go, whether it's related to the topic at hand or whether it's something completely different. Please type it in. We do want to address that and get your question answered. Brittany's going to be aggregating questions, and we will get to them at the end. If for some reason we run out of time, we will follow up with everybody. So let's go ahead and get started. So Dr. Bryan, our first question we wanted to tackle today was, how has the addition of fentanyl to other drugs changed how you and your team tackle the opioid epidemic? And what trends are you seeing as a result of this change?
Thanks, Barbara. It's a great question. What we are noticing here, particularly over the past 6 months, is that we are seeing significant increases in the amount of opiates, particularly fentanyl, that is found in other drugs that people have been consuming, such as stimulants, methamphetamine, cocaine, crack cocaine, as well as marijuana and prescription pills as well. what we were discussing an incident that happened about a month ago, 2 months ago at Ohio State, in which two students went to purchase drugs, Adderall, which is a medication often used to help people cram for exams. And unfortunately, the Adderall that they received was pressed with fentanyl and potentially some of the newer opiates that we'll talk about in this section. Mm-hmm. But when they took those pills, it unfortunately resulted in an overdose and their death. And this is a really alarming sort of trend, because in particular, when we think about opiate addiction and we think about people who are using fentanyl, we are considering that if they have an opioid use disorder, then they likely have a significant tolerance to opioids, including fentanyl. This allows them to use much higher levels of fentanyl, and their body works in this tolerance to counteract the effects of fentanyl so that the user is able to use more and more and more over time. This is how people with opioid use disorder are able to use such large doses of opiates compared to what the general population may use, where general population might be using 5 milligrams of oxycodone for pain control, and then a person with a substance use disorder is using anywhere from 90 to 180 milligrams of oxycodone. The reason why we really talk about this is because when you start putting fentanyl in other drugs, typically those who are using those drugs do not have such a strong tolerance to opioids. And since typically they're being pressed with fentanyl, because fentanyl has become extremely cheap, it's very potent and requires a very little amount, that this puts them at risk, much even higher risk than your typical person who is out using opiates on a daily basis. With this person who maybe is a stimulant user, they receive either methamphetamine or crack cocaine and it has fentanyl in it, and their body is not prepared having the same tolerance as an opiate person with an opioid use disorder would have. And so therefore it's far more deadly. And this is extremely concerning. I think back even just a few years ago, where we sort of had this understanding that if you bought pills off the street, they were probably what you were getting. Now, unfortunately, it's really kind of a guess or shot in the dark as to what you are getting, whether it's marijuana, does it have fentanyl in it? Cocaine, methamphetamine, does it have fentanyl in it? Are these pills pressed with fentanyl? And in so doing, we have people without such high opiate tolerances being exposed to incredibly potent drugs like fentanyl, and therefore this makes them much more susceptible to overdose and death.
I think this is a dumb question, but I want to ask it. The reason why they're pressing these pills like Adderall and whatever with fentanyl, is it to increase addiction and craving so they need more? I mean, because they're killing people.
Yeah. So it's actually a combination of things. Recently, I read a study, and it really was pointing to a twofold mechanism with this. Number one, as marijuana has become far more prevalent, the prices for marijuana have significantly decreased. Therefore, it becomes a far less money-making sort of an item. And so if that's the case, in order to maintain your income, then a drug dealer would want you to take something that is far more expensive, far more potent, and requires far more frequency in the amount of use. And so fentanyl, being extremely cheap, extremely potent, can ultimately come in to a level where, when you factor in the strength of fentanyl versus heroin, you factor in the differences in the costs of morphine versus fentanyl, it's really about 100 times less expensive as typical heroin would be.
Okay, so it's purely a business decision. It's high margin, even though there's risk of losing your, I hate to say this, but customer to death. You have a high margin, and I thought that was the answer, but it just still always just shocks me to hear that.
It really is unfortunate. In addition to that, when you really look at a person who's purchasing marijuana, they are maybe purchasing once a week with a small amount of money versus someone who is addicted to fentanyl, who is purchasing at least every day and sometimes multiple times during the day. And because of that, it certainly increases the profitability if your person is unfortunately addicted to opiates versus marijuana.
Okay, thank you for explaining that so much better than my basic understanding.
All right. So if you look at the first graph that we've got here, this is very simple concepts, but these graphs really show it really well. The first is showing opioid deaths that involve heroin and other opiate involvement. And so you can see that over time, the light blue is the just the heroin itself, whereas in the green is heroin combined with other opioids, typically like a fentanyl type of product. And you can see that the graph has really started to switch in 2018, 2019, and that graph is going to continue up in trends. If we go down to the next graph, this is one that is particularly specific to the use of methamphetamine. And right around that same time, 2015, 2016, people who were using methamphetamine who ultimately overdosed because of an opiate has dramatically increased. That's maybe even a 10-fold increase from 2013. So that is a very alarming concern. That graph is very, very indicative of a large concern that people with methamphetamine are being more and more exposed to opiates that can result in overdose.
All right. We know that MAT treatment, or MOUD, can be key on the road to recovery. What barriers have you been encountering when it comes to initiating your clients on MAT?
Another great question. One of the things that I really want to make clear is that probably the best defense that we have against unintentional drug overdose is MAT. And this can include a grouping of medications, one being buprenorphine, another being naltrexone, and then we have a couple of others that we may use. But primarily, what these substances do is they bind to the same receptors as the drug would bind to and block the drug from binding to those receptors. Therefore, if a person were to use fentanyl and they had taken one of the forms of MAT, it would protect them from overdose. And this is what we see as probably the most effective way of decreasing overdose deaths. Now, what barriers do we encounter? Number one, there's stigma, unfortunately. A lot of people feel that they may make the argument that, aren't I just trading one drug for another? As well as if, I'm not clean if I'm not off of all medications. And I think that, unfortunately, this stigma sort of floats around out in the community where some people have done it via just abstinence, and there's sort of like a back and forth between, if you're on a medication, you're not abstinent. So that's unfortunate and part of the stigma out there. Secondly is that providers have this idea in their mind that it's like, we have to get them off of these medications once we start them on it. And ultimately, the literature really shows that people who remain on MAT are far more successful than those who try and wean off MAT, especially within the first year to 2 years of treatment. Don't get me wrong, I'm happy to work with patients that have a very robust recovery program wherein the medication is just a small part. Absolutely, we will work to get them off of the MAT. However, in a lot of cases, their recovery program is more is not considered robust and contains a couple of things. And so therefore the medication is a significant part of their recovery program. And in doing so, if we were to take that medication away, we would leave them without much support and greatly increase the risk of relapse. So there's that stigma. There's also the idea that you need to come off of this medicine. You have to wean off of it as soon as possible. And then finally, there are a lot of providers who are not comfortable providing treatment. For instance, one of the things that I can say about the X waiver, which is required to prescribe buprenorphine products, that X waiver requirement, I believe, has almost set this up as in Suboxone is a medication, buprenorphine medication, that is highly specialized. You have to do this special course. You have to have this waiver to be able to prescribe it. And so therefore it's this big, scary monster that we just don't even want to touch. Mm-hmm. When in reality, if you compare, as physicians, we're able to prescribe OxyContin 80 milligrams. And we're worried about a Suboxone, which is far less potent. It's a partial agonist and is very safe because it has a threshold in which it no longer increases the opioid effects. And so we seem to be very, very scared of buprenorphine, but yet we're writing OxyContin all day long. So that's another part. And then knowledge. There's still a lot of substance use disorder knowledge that is not out in the general public. It's improving. I think absolutely it's improving. Webinars like this, information provided by Relink, educational resources that are out there, the prevention teams that are out there, they are helping to spread the education. And I think as it grows and more people become familiar with the chronic disease model, I think that you will see a lot of other providers sort of jumping in order to make the diagnosis. They feel comfortable treating the diagnosis. And I think that would be a significant increase of people that patients that we could get on MAT.
I had a quick follow-up question before we go on to the next question and go on to Rachel for a second. Do you know the history? I mean, I'm a pharmacist, as you know, and I remember you're right about the stigma, because even as a pharmacist, you're like, oh man, the buprenorphine, it's so much paperwork, it's so much, do you know the history of how that happened? Because again, when you think about it logically, why would it be so much easier for one drug over another?
I am not sure. Right offhand, I would have to relook it up. I want to say
I'm not either. I feel like we should know that, but I really don't know. Just something just happened.
I've definitely known it, but unfortunately, it's slipping my mind right now. I believe it was something regulatory where it needed its own special scheduling, and so you had to receive a waiver in order to be able to prescribe it because you were saying, "I've done something special to prescribe this regulated medication."
Yeah, it's not like a Schedule II.
Yeah.
I mean, it's just interesting.
Yeah, it's nowhere near the dangerous drugs that we can actually prescribe.
I know, it's fascinating. It's fascinating, but not in a good way. Yeah, very interesting. All right, our next question I'm going to have Rachel answer, and then and Dr. Bryan's already been answering it in regards to what he's seeing there at his clinic. But Rachel, as you're out in the community attending meetings, what are some of the trends that you're seeing when it comes to demographics and overdose trends?
Well, a couple of weeks ago, I sat in on a meeting at the Summit County Opiate and Addiction Task Force, and they were sharing that they have seen a rise in overdoses in African American females. And they were also saying that fentanyl is the drug that twice as likely to kill someone in an overdose as all the other drugs combined. So 60% of all of the overdoses this year in Summit County at the beginning of this year were from fentanyl. They were also saying that as of last year in 2021, which would be on the next slide, that they have had an increase in number of overdoses. It actually topped what 2017, which was the highest number of overdoses that Ohio has ever had.
Yeah, it's a very alarming trend that we're seeing. I don't know if you wanted to, I'm sorry, I'm doing your graphs backwards, I think maybe, but these are actually coming out of Cuyahoga County, some of this data, right?
Yeah, so the first one, yeah. So this was showing that the difference in the drugs, and you can see that the dark blue line, which is at the highest point, is fentanyl, and then the other drugs below it combined, it's twice as that, attributing to twice as many of the overdoses as the other drugs combined.
Yeah, it's very, very
And
alarming.
then this was in Cuyahoga County. So you can see the trends from 2017 to 2021, and it actually has been more deaths last year ever in Ohio, the most that they've seen.
Anything different you're seeing in Franklin County than what we're showing here, Dr. Borland?
No, unfortunately, we're seeing very, very similar outcomes.
Okay, yeah, it's sad, but unfortunately true. Another hot topic that we've been hearing about lately is the new analogs. Can you tell us a little bit about some of these new analogs and the challenges they bring to you as a physician, you know, running a treatment program like you're running?
Yeah, it's really a remarkable field, addiction medicine these days, because you know, your typical cardiologist, they've understood the heart for quite some time. They know the anatomy, they know various medications that affect the heart. And so they're really working with something that, although there are certainly some changes in technology, in general, their field is fairly not rapidly evolving. However, imagine with addiction medicine where 3 years ago, our entire efforts and focus was on treating heroin addiction and heroin overdoses. Unfortunately, now we have a whole new appearance of fentanyl. And so we were starting to get some new data and starting to figure out some things with fentanyl. And then now here again, we have fentanyl showing up in these other drugs. And so that's become a new thing that we're watching out for. And then finally, fentanyl in and of itself will possibly disappear like heroin did, as there are stronger, more potent versions of fentanyl that we may see and have seen on toxicological studies of patients who have overdosed and died. So it's incredibly, I don't even want to say interesting. It certainly keeps us on our toes that as we're making strides, we're also having new things evolve so quickly that there's really not even literature out there. Barbara, as you probably know, medical literature takes quite some time to be evidence-based, randomized, peer-reviewed, and that can take years, where we went from heroin to fentanyl almost overnight. So we had very little literature. And right now, with the new substances that we're finding, especially these new medications called nitazenes, which are originally used for being some very potent painkillers back in the 50s, now we're seeing them emerge, and literally there is almost nothing on the internet to give much guidance. I pulled up some documents recently. The BCI in Ohio has been tracking this. They just released their most recent data in the past 2 months. And we're seeing, unfortunately, sort of the same sort of increase in nitazines that many other states, particularly out west, are beginning to see too. With nitazines, rather than being this fentanyl analog, this is a very different analog. And because of that, we don't know necessarily how effective is naloxone or Narcan. We don't really have studies on that. How, is Narcan even effective? Do we have to find another drug or another medication that we can use to reverse overdoses? So there's all of this unknown territory that sort of takes everything that you know about addiction medicine, and then all of a sudden everything changes again. And now you're back to wondering, the basic questions in our field of, well, we treat overdoses with naloxone. That everyone knows that. Now we're being forced to sort of rethink the wheel again, starting from scratch, because we don't know how these new drug classes are going to affect.
This is definitely really scary. I don't know if there's anything else you want to comment off of this, but this is some of the cases.
Yep. And that's just by quarter. Quarter 1, 2021 on the left, quarter 2, 21, quarter 3, 21, and then quarter 4.
Look at 2022. Wow.
Yep. Quarter 1 of 2022, unfortunately, really bumped up there.
Mm-hmm.
And this is very concerning, because this really is a drug class that we don't know a ton about.
Yeah, it's absolutely scary. Like you said, it's constantly changing. Wow. All right.
And if you see there, right on the screen that you're at, recent studies showed that the potency of nitazene compounds vary, with some being 1.5 to 40 times more potent than fentanyl. Like, how is
I can't even imagine that. I mean, because fentanyl is measured in, for the tiniest of dose, like the speck of a crumb is how you weigh out fentanyl. Yeah. I can't even imagine, how could you possibly put that in anything in a dose that wouldn't kill somebody? Like, yeah, I don't know. It's such a tiny amount. It's like a speck.
Yeah.
It's mind-boggling. All right, we can get copies of some of this for everybody, yes, as you're interested as well. I'm going to go back to the other presentation real quick. I do see some questions coming in, which we'll get to at the end, as we want to leave time for that, which we should have plenty of time to do that. All right, back to the slides, going to my next question, hopefully. And I think you've kind of answered this one a little bit. Is naloxone effective? It sounds like we don't know for sure, but it sounds like the advice to EMS has been, make sure you have more naloxone with you, because you're going to probably need it.
Yep.
Is that a good summary?
Yeah, that's the guidance that we have right now, is expect increased doses of naloxone. Now, when we hear that, I kind of think in my head, is there, two different ways that we might need this? Because one would be, okay, it's a more potent drug, and so we might need more naloxone for that. Or is it because naloxone's not as effective as it is on your typical synthetic opiates, such as morphine, heroin, and fentanyl? So that's kind of our questions that are out there right now. And like I said, I don't have hardly any literature on it.
Yeah, that's the thing. We just don't know right now, do we? It's just going to be, unfortunately, an experiment. Have you seen in your practice anybody coming in that has had, experience using these? I mean, do people know they're using them, or is it an accident when they're getting something else, or how does that come about?
Typically, I have not heard patients discussing these drugs. I will tell you that really, this is so new that we weren't able to begin even testing for these until the past couple weeks, because they're that new on the scene. And so test panels had to be built so that we can actually begin testing and sort of breaking this down as to Is this fentanyl? Is this a fentanyl analog? Or is this a nitazene? We really had to restructure our testing to be able to answer those questions.
Yeah, I can imagine. I mean, that's just a huge challenge. You don't even really exactly know what you're dealing with.
No.
All right, this is kind of our last question we're going to go through today, and then we wanted to leave plenty of time for your questions. So Brittany, I'll have you getting the questions ready there. And we just wanted to share a little bit of data that we have from relink.org, and we have so much data we could share. We don't want to inundate, but we just did. I had Bill pull some data on harm reduction. I know that that's been, back in 2017 and 2016 when the opioid epidemic was raging, but kind of more in a newer stage. We were doing a lot with harm reduction, and there's been so much going on with harm reduction. That's been great. And then these challenges have come in with the fentanyl, the new analogs, the pandemic, which has made the work so challenging. But we just wanted to share this data. I ask everybody who's on, if there's any data that relink.org can provide or share with anybody, to just reach out to us. I believe we have our emails on here. If not, we can type it in the chat. Bill, go ahead and type in your email or the info@email in the chat to reach out to us. But we have a lot of data that we're happy to share with people if it's helpful. We've seen, as far as searches go on relink.org, there's thousands of people that use relink.org every week, and we're seeing a vast increase in the amount of people searching for these resources. Here's just a little bit of heat map of where the resources are available. Nothing too surprising, as they're more readily available in the urban areas. A lot of different addiction prevention programming as well is out there. This just kind of highlights all the different resources. All these resources can be found on relink.org. Some naloxone programs, again, concentrated a lot in the cities. These tend to be very detailed dispensing programs, tracking outcomes and things like that, so they can get some good data on their effectiveness and their impact in the epidemic. And there's some of our information there, but we're not really done yet, even though this is our thank you slide. I do want to go to the questions next. I know there's quite a few. Brittany, do you have a question ready to go that you can ask?
Yeah, there's a few here. The first one is there a relationship to the long-term impact to the brain of babies born to mothers who continue to use or abuse the fentanyl and other polysubstances during their pregnancy and CTE?
Fantastic question. And
You're muted.
Oh, I can hear you, Dr. Bryan.
Oh, yeah, there's
Oh, never mind.
What I've used in the past to show people is there's some data that came out in JAMA, Journal of American Medical Association. It was about alcohol use disorder. And what it showed was that really there are two scientific things that we can prove increase the likelihood for someone to have a substance use disorder later in life. And the two of those are, number one, it's a genetic predisposition for substance use disorder. And then number two, age at which you first began using. On average, the ages that I hear in assessments is typically around 13 for beginning to use something like marijuana or alcohol. And so if you look at the graph, if you have a genetic predisposition and you use at 13, you have a 66% chance of having a diagnosis of substance use disorder later in life. So that's 2 out of 3. And even if you don't have a genetic predisposition using at 13, you have a 33% chance. So 1 out of 3. The question that I always ask when I present this data is, I then go all the way back past the graph and write a 0 and say, what about here? And everyone at that point in time there, that you can just see their minds trying to comprehend what that could potentially be. because honestly, I don't know. I don't know what if you were exposed to fentanyl or other opiate medications early in life, if that would affect your likelihood of being diagnosed with substance use disorder later in life. I don't know the answer to that, but it seems concerning. The hopeful argument against that is that when you have small children, babies, neonates, their brain has a lot of development that's still going to go on. So it's literally like some soft clay in regards to, there's a lot of molding that can happen between exposure as a neonate or young child into later in their teens, so that there's hopefully some rebuilding that takes place neurologically that allows them to sort of restart their brain without the impacts from the earlier exposure.
So the next question is, have you seen any positive screenings or overdoses as a result of isotoniazine?
At this point in time, we just started testing a couple of weeks ago. We have not seen it, but when I've talked to the coroner, Columbus coroner, they have seen it. And I believe the last that I heard was that they had about 40 some cases in Columbus. And so that information came from the coroner's office, actually.
Okay, the next question is, have you had any experience using nalmefene in overdoses?
I have not. I have not.
Okay, and then are there stronger doses of Narcan available?
There was just recently released an 8 milligram dose. It had been 4 milligrams for a very, very long period of time. They've just now released the 8 milligrams. And I think a lot of people are becoming more aware that you are probably going to require multiple doses of Narcan in order to reverse the effects of these really, really potent opiates, synthetic opiates such as fentanyl. I have personally had to reverse overdose from fentanyl here at least probably 10 times. And I can tell you on average, we were using between 4 and 8 doses of the 4 milligrams to
Oh my goodness.
To get a decent reversal. And I'm not talking about like, we gave it, they're up mad, they're screaming, they're like, why did you do that to me? It was literally to just get them to start breathing a little bit on their own again. And then we had to monitor them after that. It's not even like we threw them into florid withdrawal. It was just getting them to the point where the respiratory depression had stopped.
Wow, that's more than I had heard.
Yeah.
Okay, the only other thing is someone said that they saw something years ago about having someone drink whole milk to reduce an overdose in cases of amphetamines or drugs containing such.
That's an interesting thought because amphetamines typically are pH specific that make them very effective. And so the thought is, if you alter the pH of the stomach, maybe then you wouldn't have such of a response from the amphetamines, and so therefore it might be able to prevent them from having an overdose. But oftentimes you'd literally have to try and take the milk right at the same time as the person overdoses. I think by the time the person overdoses, you're already 15 to 20 minutes into it, and by that time it's probably ineffective.
Okay.
Yeah, I hadn't heard that before. But
and then have you seen any overdoses from the analogs of fentanyl?
Again, we just started testing a couple of weeks ago, and we have not seen any analogs yet.
Okay, I think that was the last question.
And then I saw a few comments in there about sharing some data and sharing the slides, and we will definitely be happy to share all of this information with everybody. If there are any more questions, please type them in or even raise your hand. We can let you share if you'd like, because we do have a few extra minutes, or we can let everybody go a few minutes early. Dr. Bryan, do you have anything else that you would like to share regarding the trends and things you're seeing? May want to take a minute to share a little bit about the Begin Your Climb that I mentioned at the beginning of the webinar, which the training for families that we launched earlier in 2022.
I think one topic that I'd like to circle back around, Barbara, and was probably one of the reasons that this whole campaign and webinar came about, our relationship with Relink and Basecamp Recovery, is that right now, this is a very dangerous world with the type of drugs that are available. If you really want to have an impact, I would recommend that particularly families really start educating about this early on, talking about the possibilities that, you know, it may not be marijuana that you're getting if you purchase drugs, or, you know, even if you think you're getting a pill, these are often laced with fentanyl. This is a very, very different time. If you would have asked that question 10 years ago, I would say you could probably feel pretty comfortable if you were in college, you wanted to go buy some pills, and you were going to use them to study, some Adderall. I would say that you probably could have felt pretty comfortable that in doing that, you were going to get Adderall. That is not the case right now. That is absolutely not the case. And I think we have to make our families aware of that, because this threat of danger and threat of overdose is so significantly higher right now that we really need to be talking to our kids about the importance of not using drugs, as well as even some of the smaller drugs that they may think are perfectly safe, the possibility that they could have fentanyl mixed into them. And so that makes them, literally, I look at marijuana right now as just as dangerous as fentanyl, because you just don't know anymore.
Yeah, you're right. It is just so scary right now. Do you have a minute? Maybe you don't have this in front of you, so you can say, I don't know. But from the Begin the Climb training sessions, there's 4 that have been active for families, and any information from the number that have taken it and some insights that you're getting from that?
So I believe we shared the data earlier, and the data has stayed pretty consistent. So what we're typically seeing pre-test and post-test, Begin Your Climb is an educational website in which you can go. It's beginyourclimb.com. It's completely free, and you can create a login, and that gives you access to 4 educational videos. This is totally free. You can make your login completely anonymous if you want. But we've really been watching the data, because we ask you to do a pre-test, then you're able to watch the videos, and then do a post-test. And it's been really rewarding to see that the general public, most people start off on the pre-test around 60%. Typically those that had the 60%, the general public, when they finished the course and did the post-test, they were up to right around 80%. So pretty significant change in the level of education. Secondly, I spread out all of the people, and I created a healthcare-based group. And that healthcare-based group, their typical pre-test score was right around an 80. And when they were finished, they were averaging easily into the mid 90s. What's interesting about that is if the healthcare providers are coming in and doing the pretest and getting an 80, and the general population who are coming in pretest much lower, but then finishing pretests around, or the post-tests around 80, it makes me feel rewarding that it seems like we have significantly increased the level of knowledge in just the general population to at least to the point where they may be equivalent in some cases to actual healthcare providers.
Mhm. Yeah, and another thing I wanted to touch, the education and the prevention, and you touched on it a little bit today, and I know you've touched on it in the past, but this age of first use, like you said, the outcomes for someone as their brain is developing and starting to use at 12, 13, 14 versus someone who maybe has their first encounter with these drugs at 25 or 26 and the outcome they have. And so I think that's one of the reasons I know we're so passionate about education, whether it's the family, the children that are watching another family member go through this, on how we can help them educate themselves to prevent, because the earlier they start, it just tends to be a worse outcome. And that validates what you're seeing, I assume.
Absolutely. Yes, the other thing that I would certainly encourage is talking about that, particularly in families where you've got a pretty good idea that there's a genetic predisposition. So mom, dad, sisters, brothers have had opioid use disorders or stimulant use disorders, alcohol use disorder in the past. That's probably a person that it might be, very informative to them to let them know that they are at a significantly increased risk of developing a substance use disorder later in their life. And so for them, it's super, super important that they try to not experiment with drugs, try to avoid drugs if at all possible, as well as letting them know that, like, the earlier that you start using substances, it greatly increases your chance for having a substance use disorder later in life. And that's not something that you want to have. And so just keeping that in mind, bringing it up to the family, mom, dad, sisters, brothers who have alcoholism or substance use disorders, that their family should really be aware that likely they have an increased risk of having substance use disorder later in life.
Yeah, that's great. Thank you. We've
We
got
have
one
one
other
more
question
question.
that popped in real quick that I'm going to read. And then also we had someone type in a good answer about the milk, that by drinking milk, you dilute the detergent or other poison, you overwhelm the lactase enzymes, allowing your stomach's hydrochloric acid to curdle the milk, which coats your stomach and intestines, slowing down the rate with which your body absorbs the poison. So that's a little biochemical of what's happening. But
There you go.
as
There
you pointed out, you got to get it pretty quick, because if someone's passed out,
Yeah.
it's too late and you can't get them to drink milk anyway. But interesting. Thank you for adding that. And then
Yes,
one
thanks.
last question, which I think is a really good one. Can you speak to any current trends regarding treatment retention? Have you come across any factors that encourage or discourage treatment adherence?
Great question.
Yeah, I thought it was really good.
That's a fantastic question. What we typically see retention-wise really depends upon a couple of things. Number one, you will retain patients if you are able to respond to their needs immediately. This is a disease where a person who walks through the door, this is a monumental accomplishment for them. They need to be let know that you're very proud of them, that this is a really big deal, that you're so appreciative that they're here and excited to help them, and you're able to respond right away. If you tell a person that you're going to have to wait, or we can get you in next week, unfortunately, that really, really decreases the amount of people that are going to be retained in your program. So that's one. Number two, I think MAT is an important part of the program. If you are able to bring someone in who is actively withdrawing, and you are able to alleviate that withdrawal with medications such as buprenorphine, then you are also increased likelihood that you're going to have patients retained in your program. At Basecamp, those are two major determinants of what we do. We turn no one away. We treat this as an emergency room. If you walk in the door, you will be seen. You will be seen immediately. There will not be any delays. And if you need medication, you're evaluated by a nurse within 15 minutes of arriving and a nurse practitioner or myself within 30 minutes of arriving. And so you can be assured that you will feel comfortable. And this really enhances our ability to retain numbers of patients up in the 50% to 60% range, which in general, I would look at the averages from treatment centers that don't have those two things as being lower in the 20s to 30s.
Okay, thank you for adding that. I have gotten to visit Basecamp, and it is like an emergency room there. It's whenever you come in, I guess you don't get to plan your days out too well. You have your plans, and then
Yep.
it happens, right? Because there's
Yep.
whatever comes in, you take, and that's wonderful. Well, we are just about out of time, and I thank everybody for the great questions. I thank all the relink.org team for preparing, and of course, I thank you, Dr. Bryan, for always sharing your incredible knowledge with us. We will be sending a follow-up email. We'll include the slides. And if there are any other questions, you can reach out to us. So thank you, everybody, and have a great rest of your day.
Thank you.